Part 2, injuries. So we're going to talk about high specificity injuries. And what we mean by that is when you see a particular injury, you want to know, could this have happened by accident or not? If it's not likely to have happened by accident, then you're calling it a high specificity for abuse injury. Another way to think about these particular injury patterns are kind of weird fractures. You don't normally think about these fractures, and it would be hard to imagine from, let's say, falling from a crib or a caregiver's hands, why you would sustain these types of injuries. So let's talk about what they are. These 5 lesions, classic metaphyseal lesion, also known as a CML, rib fractures, spinous process fractures, sternum fractures, and scapula fractures. Those last 3 all start with S, so that's also another way to remember the S sound, like sinister. These are injuries that are not likely to have occurred by accident, meaning they are concerning for abuse. What is a CML? So you look at this X-ray and you see these additional slivers of bone. Now, if you're not used to pediatric radiology, you might say, I don't know, is that the ossification of the epiphysis? No, it turns out that most ossification centers in pediatrics tend to be ovoid or softer looking. They tend not to look like slivers of bone. What these slivers of bone represent are little pieces of the metaphysis that have been ripped off. To understand that better, let's look at some illustrations. The ends of the long bones are all cartilaginous. And you might think that if there were an injury to happen, that it would be the bone-cartilage interface that would fail. That's usually what happens in nature, that you have an interface of 2 different substances, 2 different compositions, that failure is right at that junction. In this case, that doesn't actually occur. The failure is actually between the long stem of the bone and the bone that's just barely attached to that cartilage. So it's this undermining effect that's actually the weakest point. The bone cartilage remains intact, but deep to that bone fractures. And it's somewhat lucky that this is the pattern, because if it were just a physeal cartilage injury, we would miss it on X-ray. We would have to wait until we saw healing changes. So the fact that we can see this injury pattern is a little bit lucky that we catch that sliver of bone. This, unfortunately, is an autopsy specimen. And what these black arrows are pointing to is that purple line, which represents the fracture, again, through the bone itself, not through the bone cartilage interface, although that is right nearby. So we hope to never get to this kind of specimen. We hope to catch it when it's just an X-ray, as we see on the left, and does not ever go to autopsy. So once again, that is where that fracture is occurring. Unfortunately, some more autopsy specimens, but just they are informative, so we will discuss them. Again, it's thought that this is a shearing or twisting injury of the extremities, again, that rips off that little piece of metaphyseal bone. It's that tiny little sliver that we see on the X-ray of the autopsy specimen on the left and the gross photograph of the specimen on the right, that little sliver of bone is what breaks off, and that is what we are seeing on the X-ray. On the sides, if given enough time, you will have hemorrhage, which then calcifies, so-called subperiosteal hemorrhage. It will look like healing callus or periosteal reaction. That will also manifest on the radiograph, although that takes a little bit of time. So let's see some additional examples. So the CML comes by a number of names. It's known as the corner fracture, the bucket handle fracture. And the reason it has different names is because depending on how you catch it, it may have a different appearance. Here it just looks like the corner of the metaphysis is broken off, so it's called a corner fracture, but they're all the same thing. The common locations are going to be in the long bones, and particularly the proximal humerus, distal femur, and both proximal and distal tibia. It's going to be the most helpful and the most specific finding, particularly in infants who are less than 1 year of age. Here it looks more like a bucket handle. So that crescentic piece of bone that has been pulled off, we're catching it in such a way that we catch it looking more like a curvilinear opacity rather than a triangular corner opacity as we saw in the previous slide. Now, if you give it some time, like with most fractures in kids, the bony callus will make it easier to detect. So as I alluded to earlier, because of the normal uptake in the physes, as you can see in the scintigram on the left, this is a bit of a degraded image on the right, but there is abuse present, radiographically proven. It's just a little bit hard to tell exactly where it's occurring because the normal uptake at the physes is right next to the abnormal uptake that would be associated with a classic metaphyseal lesion. Here is our next injury. So we're moving on from classic metaphyseal lesion. We are now talking about rib fractures, still high specificity injuries, also most specific in infants less than 1 year of age. And we see in this image, and also the patient did have a subsequently performed CT, that there are healing fracture calluses at the posteromedial aspect of the ribs. The thought behind how these injuries occur is due to a thorax crushing injury by the perpetrator, which results in several fracture locations. There's going to be fractures that can occur in the front, in the back, and on the sides. Our next high specificity fracture, starting with our S fractures, the spinous process fracture, presumably due to a direct blow to the back of the victim. Spinous process fracture is really something that should never happen by accident. What about the sternum? Thought to be due to a direct blow to the chest. Here we see an ossification center that is fragmented and misshapen. This is CT and follow-up appearance as well, showing again this irregular appearance. You're really only going to catch this on your lateral views of the chest. And if you happen to be performing a CT, your sagittal reconstructions of the chest. These are easy to miss and almost impossible to detect on a frontal-only projection. Also still in our high specificity and also our S fractures, scapula, particularly the acromion, thought to be due to a direct blow to the back of the shoulder girdle. We see here that this acromion is fractured, kind of where you'd expect it to be at sort of a thinner, weaker point. This is a very high specificity injury, one that should not be occurring by accident. So these are the most specific injuries. These are the most important injuries to know about from this lecture. We're going to move on to fractures that also could be due to abuse, but they're not as convincing for abuse. They're not as specific for abuse. So in this moderate specificity category, we have a lot of injuries that you may have learned in med school are associated with abuse, but aren't as specific as you may have thought they were. So starting off, we have a radiograph of an ankle and foot, and we see multiple fractures. So multiple fractures in and of itself is concerning. It's only moderately concerning, but it's still concerning. This radiograph also has another appearance that is of moderate specificity, and that is of digit fractures. In this case, the great toe phalanx and metatarsal. That is a moderate specificity type of injury for abuse. Also, spine, particularly the vertebrae. So we're not talking about spinous process, now we're talking about vertebrae. And in particular, you can have slamming injuries that will lead to displacement of the sacrum and coccyx. You can also have shaking injuries that will also lead to depression of the vertebra. That here you can see it's more trapezoidal rather than its neighbors above and below that are more square-shaped. Here we have a 3D reconstruction of a skull, and you can see that there's a depressed complex fracture in the back of the head. And that's pretty easy to identify, especially with these 3D reconstruction CTs. And you should also make note, these are the Mendosal sutures shown with the curved arrows. Mendosal sutures are normal in and of themselves. Now, on the left, you can see that that Mendosal suture is blacker because it's more diastatic, meaning that the fracture has extended into the Mendosal suture. But be aware, the Mendosal suture in and of itself is a normal finding, and if it's not diastatic, should not be called a fracture. It is the most commonly called fracture that's actually not, because people lack familiarity with this normal suture. So these were the moderate specificity injuries. Again, the ones that at least I in med school remember being taught are more specific Turns out they're not as specific as our earlier category, but they're still of high concern. We're now moving on to our low specificity injuries. These are things that can definitely happen by accident. They could also happen due to abuse, but you can't be as confident and suggestive of abuse. You have to have a differential. As you can see, periosteal new bone, there's lots of things that could cause that. Clavicle fracture, commonly seen with birth delivery, long bone fractures, being caught in cribs or falls, and linear skull fractures. So not all skull fractures are of high specificity. So periosteal new bone can occur due to a non-displaced fracture, can occur due to systemic stress, osteomyelitis, adjacent cellulitis. It happens basically when anything is bothering the bone, and it does not have to be due to abuse. It does not have to be due to even a fracture. It's something that could be a sign of abuse, and this would be the kind of thing that if you saw it on a survey, this might be an example where you might want to get follow-up, because what if you do the follow-up and other areas now have periosteal reaction? That's kind of weird and would be concerning. So this would be a good use of that follow-up survey if you were to encounter isolated periosteal new bone. And here we see it on this tibia at the medial aspect. Clavicle fractures occur frequently with vaginal delivery. They're really of no consequence. We see them pretty frequently in the newborn nursery. It's not that it couldn't be due to abuse, it's just that it's probably more commonly not due to abuse. You have to report it, but you're not going to be saying this is a high specificity injury. And here we see it here, slightly displaced. You would think that a fracture of a femur ought to be abuse. It doesn't have to be. And here we also have a fracture on the right of a tibia. One thing that's useful here is to establish, is this patient walking or not? In a non-ambulatory patient, you're going to be worried about fractures more than ambulatory because the kids are falling, they're learning how to walk. So in these two images, they're two different bones, I admit, but perhaps more importantly is the history. The non-ambulatory patient, this was due to abuse. This ambulatory patient, this is the classic toddler's fracture, which sounds scary, but is just a common fracture that occurs in toddlers who are just learning to walk. It'll be a spiral fracture of the tibia. It's very common. Not that it couldn't be due to abuse, it's just low specificity. It's probably unlikely to be due to abuse. You would think that all skull fractures ought to be concerning for abuse, but if you were to fall from a crib and land on a hard floor, you can get a skull fracture. It should be a linear skull fracture, as we see here in this X-ray and 3D CT reformat. Not that it couldn't be due to abuse, it's just, it's not specific. So these, again, were the low specificity injuries. That ends our segment on injury patterns. In a moment, we're going to move on to our third segment, which will deal with mimics and dating.